Hi everyone. So today we're going to talk about drugs for hyper and hypotension. And once again, this is a brief overview because there's a lot of medications that we use for both of these issues. So first of all, to talk about blood pressure and what makes a blood pressure happen is these three different things. So first, you have blood volume. So how much blood volume is actually inside your blood vessel? So try to remember when you were a kid outside playing with a water hose in the summer. And so if your brother is over there at the spigot and he turns it on just a little bit, you're only going to get a little bit of pressure and a little bit of water, and you can actually get a drink. But then, as all brothers do, he goes over there and he cranks it on and you're trying to get a drink and all of a sudden pressure in your face, right? So he's giving you lots more volume, lots more pressure. So that's exactly what happens in your blood vessels. With more volume, you have more pressure. What can lead to less volume? Fluid loss, dehydration. And what can lead to more blood volume or fluid retention? The aldosterone system and ADH. Those are what those two components do. So then the second piece is peripheral resistance and diameter of the arterioles. So once again, if your brother decides he wants to spray you and get you all wet, what does he do? He puts his thumb over the end of the hose and he starts spraying because the water comes out with much higher pressure because you've blocked the end of it. And so in essence, you've made a much smaller hose, right? And so that's what happens with your blood vessels, a much smaller blood vessel. And so the sympathetic nervous system activity does that. When a bear comes up behind you and scares you, it clamps down, gives a lot of volume to those vital organs. And so it gets small and it increases your blood pressure. The renin and angiotensin system, too, definitely does that. And also increase in blood viscosity. If your blood is thick, then you're going to have more blood pressure. And then last is cardiac output. So stroke volume, preload, contractility, afterload, all those things are related to the pump, to that left ventricle of your heart. So once again, with our water hose analogy, if the well pump isn't working at your house in the country, then you're not going to have any stroke volume because nothing is pumping through, right? And then heart rate is the last piece. Your sympathetic nervous system, parasympathetic nervous system activity, and your epinephrine activity. All of those things are going to either increase or decrease your blood pressure, which if your pump is pumping faster, you're going to have more blood pressure. And if it's pumping slower, you're likely going to have lower blood pressure, except sometimes you have better diastolic filling when you go a little slower, so you might actually have a little bit better blood pressure. So that's kind of a 6 of one, half a dozen of another thing. Okay, there are types of hypertension. Primary hypertension, which we don't really know, what the identifiable cause is for that. Secondary hypertension, the cause has been identified. So either Cushing's syndrome, hyperthyroidism, chronic renal disease because of all this aldosterone and angiotensin and renin system issues. And then certain drugs can also increase your blood pressure. Sometimes for the good, sometimes not for the good. The disease progression related to organs is you can have heart failure, you can have TIAs or CVAs, renal failure, visual impairment, and blindness. And all of this is related to the fact that inside that blood vessel, you've got this high, I guess I should turn around this way, you've got this high amount of pressure going through, and it's constantly berating the inside of the vessel. And so the vessel gets stiff. And we count on blood vessels to be able to get larger and smaller. But after years of being berated by flow and high blood pressure, they don't compensate as well. So that's why many of these things happen. And especially in heart failure, too, this can cause remodeling in the left ventricle. This can cause a big, thick left ventricle. We can have lots of issues with high blood pressure, that's for sure. So what are the first-line drugs? Primary antihypertensive agents. So first we're going to work on the volume, and that's diuretics, things like Lasix, potassium-sparing drugs like Bumex. Okay, those are two of the main ones we use. And then there are many other oral medications that we can give that are diuretics or mixed-up diuretics. Calcium channel blockers, which actually work to decrease the they relax the smooth muscle, and it causes the cells to relax, and I think it's important that you understand that on people that have really bad long-standing history of hypertension, calcium channel blockers may not work that great because their vessels are so stiff. But we're talking about drugs like Cardizem, Norvasc, Procardia is an old one that we used to give. Angiotensin converting enzymes, so ACE inhibitors. And so we definitely use those. Those work at by preventing the formation of a hormone called angiotensin. And that substance narrows your blood vessels. So we're talking Vasitec, Prinavil, Altase, those kind of drugs. So then angiotensin converting enzymes, that just makes it so it blocks the action of angiotensin. And drugs like that include things like Cozar, Diovan, those kind of medications. Angiotensin receptor blockers are, that's just what I talked about, isn't it? I'm so sorry. Then direct renin inhibitors, which we don't see very often. Renin is an enzyme produced by your kidneys that it starts chemical steps that increases your blood pressure. And one of the drugs, I can't even get the name right, Tecturna, not even one that I've heard of. So lots of first-line antihypertensive drugs. The second-line drugs are a little different. They are beta blockers. And, we give a lot of beta blockers post heart attack, that kind of thing. But beta blockers work by blocking the effects of the hormone epinephrine, also known as adrenaline. And they cause your heart to beat slower with less force. So it just chillaxes your heart, basically. And we're talking about metoprolol or tenormin, those kind of medications. Alpha-1 and alpha-2, or alpha-1 receptor blockers in arterioles. We definitely can use those, which we don't use all that often. Drugs like Cardura and Minipress. Alpha-2 adrenergic agonists we can also use. And once again, these are not ones that we generally use very often, but they are available to us. Direct-acting vasodilators, drugs like Imdur, drugs like nitroglycerin, that actually work on the blood vessel wall and dilate it out. Those are good medications as well. But one of the things that you can have is you can have some tachycardia with those, and we'll talk about that. And then peripherally acting adrenergic neuron blockers. So what are some things to know about these medications? And about blood pressure medications for hypertension as a whole. Prescribing two antihypertensive results in additive or synergistic blood pressure reduction. It's not uncommon at all to see a patient on 2 or 3 different types of blood pressure medications working on different pieces of blood pressure, whether it's to reduce volume, to relax the smooth muscle, whatever it happens to be doing. So when you see this, you know that this patient probably has a long-standing history of high blood pressure. Also, we want to watch electrolytes with all diuretics, because even those potassium-sparing diuretics, things like Bumex, we have to be careful with, because sometimes they still reduce potassium a little bit, it seems. Beta blockers reduce cardiac output, because that's what they're designed to do. They're designed to chillax the heart, slow things down. So it alters the body's ability to compensate for fluid volume changes. So think about that. If you're blocking those extra stimuluses and your heart's only beating at 60 beats a minute and a bear comes up behind you and scares you, no matter what, you've got that drug on board that's saying, oh no, you need to stay chillaxed. And your sympathetic nervous system is not going to work as well at that point. So, if you have someone come in that they have all the signs of sepsis maybe, but they're not tachycardic, one thing to think about is, are they taking a beta blocker at home, and is that why? ACE inhibitors can cause a chronic cough, and they do badly enough in some people that they can't take those kind of drugs, so that's something to remember. And direct vasodilators can cause reflex tachycardia, and I talked about that on the last slide. If you vasodilate, your body's going to still try and compensate and say, hey, but I was going I had that high of a blood pressure before, so I'm going to speed up my heart so I can keep that blood pressure high. But eventually, it will settle down and your body will get used to it and the blood pressure will come down. Okay, so now we're going to change our wheels and we're going to go to hypotension. We're still looking at those three components of blood pressure in volume, squeeze, and pump. That's what we're looking at. We're looking at how much volume's inside the vessel, how tight is the arterial bed, so what is the peripheral resistance and the diameter of the arterioles, and then last, what's your cardiac output? How well is your heart actually pumping? Is it effective? So with volume, our goal is to optimize the amount and facilitate movement of red blood cells and oxygen to the tissues. Absolutely. So we're going to do standard assessment things, and then we're going to decide what kind of volume is lacking. If it's not enough red cells, then we need to give red cells, or we need to slow bleeding if someone's cut off their arm and they're bleeding out. We need to give blood components to increase clotting as well. Do we have adequate blood cells, but not enough plasma volume? So maybe your H&H's or your hemoglobin's okay, but your plasma volume is low. So then we're going to either give a colloid, a crystalloid, or Hespan or hetastarch, which we don't use very often anymore. Colloids are things like albumin, which really helps to increase that the amount of solute inside the blood vessel, and it's going to pull interstitial or extracellular fluid back into that blood vessel. Crystalloids just simply fill up that vessel. So volume problems can lead to hypovolemic shock. We need to fix it quick. Absolutely. So then the next piece is our squeeze. How are our blood vessels doing right now? Once again, we have our assessment pieces. And then we have to say, why are we tight and why, or why are we loose? Are we cold and tight? Are we hot and loose? Do we have vasopressors on board making us tight? Do we have vasodilators on board making us loose? Do we have not enough volume, and so now our blood vessels are getting small to compensate for that so that it can maintain some kind of blood pressure? Was the patient just on cardiopulmonary bypass, which creates a huge inflammatory response and makes you dilate? Also, is your pump not working? And so since you're not getting much blood flow with each pump, your vessels get small to try to compensate so that you can move blood through at the rate that seems to be right at the time for your body. And then sepsis, a huge loosey-goosey time because your blood vessels have a huge inflammatory response, huge vasodilation, lots of cytokines are coming, and we have lots of permeable blood vessels. So not only are we loose, we're losing what little fluid we have inside the blood vessel into the extracellular space, interstitial spaces, and we end up with lots of edema in these patients. So we may have a lot of fluid, but we just don't have it in the right space, so the patient is intravascularly dry. So squeeze problems indicate circulatory compensation in all types of shock, but especially in septic shock. So what do we do for the squeeze? We're going to do drugs that either constrict the vascular bed or dilate the vascular bed. And I guess I have a picture for the constricted ones coming up. Drugs that dilate the vascular bed are things like nitroglycerin, which dilates the venous side, nipride, which dilates both venous and arterial side, or dobutamine, which is a positive inotrope, makes you beat stronger, gives you a little bit of dilation so that your left ventricle has a little less work to pump against. And we'll talk about the constrictors here in a second. And then lastly, for the pump, we need to optimize the left ventricular function. So once again, we do our assessment pieces. And if we're not adequately pumping, the best thing we can start is dobutamine because it helps with that pump. And if that doesn't work, or maybe in concert with, we put a balloon pump in to help these patients. So pump problems can lead to cardiogenic shock. Absolutely. And here is our final slide. So this goes over the alphas and the betas and all these vasoactive, vasopressive medications. So alpha 1s work in the vascular smooth muscle, and they increase vascular smooth muscle contraction. Alpha 2s work in the CNS, and they decrease sympathetic outflow. B1 are cardiac cells. They increase heart rate. They increase contractility. They increase renin release. B2s, vascular and bronchial smooth muscle, so it gives you vasodilation and bronchodilation. And then D1, which is the final, the renal, splanchnic, coronary, cerebral, that's where they are located, and they relax renal vasculature. So Here's a little chart for you, and you can look that over at your leisure, but basically talks about the different types of IV medications we use as vasoactive substances in that hypotensive patient. Many times norepinephrine is the drug of choice. We do use norepinephrine and epinephrine. We use all of these drugs. So have a look, and thank you so much for listening.